Good morning, everyone. I'm Jessica Lovell in for Chief Medical Officer Dr. Steve Stites today. We are here inside the Dolph C. Simons Jr. Family Broadcast Studio, and we are really glad you are joining us today. Our topic may be a little hard for some folks to hear. It is the COVID-19 connection to violence, but there is a new program that started this started last month, and we're going to tell you about it and the hope that it is offering for some people in the community. We have a strong panel here to explain this connection and what is being done to help. First in studio, we have Olivia Desmarais. She is a health system trauma injury prevention specialist. So welcome to you. Glad you're here with us. And on the phone today, we have Damon Daniel. He is the president of AdHoc Group Against Crime. And then joining us by Skype is Dr. Jomella Watson-Thompson. She is from KU in Lawrence. She specializes in behavioral psychology and urban planning. And she is the director of Thrive, which is a local youth violence initiative. So we're going to hear from all of our guests this morning here in just a moment. But first, we have something kind of special. We want to share a little bit of Amy Carrillo's story. She is a 42-year-old mom of 4. She lives in Lawrence. She was diagnosed with COVID-19 back in March. And she talks with KDHE Secretary Dr. Lee Norman in the first of a new series called Faces of COVID.
It was right when everything was just starting to shut down in America, when we were just starting to hear about it. And I had a sore throat that week. I was still at work. And, kind of joked around it, didn't think anything of it, because at that time we were really being told, or seemed like we were being told, that it was just older people. It wasn't that big of a deal. Even if you got it, you'd probably get over it. But it was mainly older people to be worried about. So I was more worried for my parents. And then I just one day was exhausted, and then just basically was in bed, and then was in bed for a full month after that. I was sick for about a week, and before I got tested, I went to the ER because I couldn't breathe. I woke up one morning and it felt like an elephant was on my chest, and like someone was stepping on my back with a boot, and it felt like there was a hole in my lung or something. I've never had any kind of illness like that. The whole time I was just being told, go home, rest, quarantine, and drink fluids. So I'm going through a worldwide pandemic, alone in my bedroom, afraid that I was going to infect my family, afraid that I was going to get the doctors and nurses sick. And my friends and family are trying to drop food off, which was so nice, but I didn't want them to go out in public. I didn't want them to, at that point, we didn't know if they could get it from touching our doorknob, things like that. So it was completely terrifying. And,
there's so many naysayers out there that say, well, that happens to old people in nursing homes. It happens to people with underlying heart disease or emphasis on those.
I thought the same thing. Yeah. I almost had this sense of this won't happen to me. And if it does, what's it going to, how bad's it going to be? Well, it's beyond my worst nightmare. My symptoms have lasted, I'm 4 months out now, and like 125 days, I think. I still have symptoms. They've only recently, in the last 2 weeks, my lungs have finally stopped hurting.
Such an impactful story. And Dr. Lee Norman joins us now by phone. So, Dr. Norman, good to have you with us this morning. What made you start this series?
Well, there were so many cases. Number one, we're getting up toward 30,000 positive cases, 365 deaths, but these stories are just popping up. And one of the things that I think we're experiencing is there's so much divisiveness out there, whether this disease even exists or not. Is it some kind of a overblown? And I think that when people tell stories, I think it really drives home the message of how serious this illness is. We've got some others that I've already done that have not been released yet. A 19-year-old, a 51-year-old man on a long time on a ventilator. And these stories are so poignant. So I just tee up a couple questions and I get out of the way and let them tell their story. I think it is very powerful.
We love what you're doing, because we really think it's about putting really a face with this disease. So we appreciate those and look forward to seeing those. But while we have you on here this morning, can you just update us a little bit about how Kansas is doing?
We're having a lot more cases. We're still averaging about 360 cases a day, but the overall 14-day trend line is getting a little better. Hospitalization rate's getting better, and the death rate is getting better. So I think that people are taking masks a little bit more seriously. Now, some areas don't take it seriously at all. But I think on balance, once we get a little bit further into August, I think we're going to see some improvement. So overall, the trend line is improving, but somewhat spotty. Problem areas still.
Dr. Norman, I know this is the loaded question. Are we ready for school in a month, do you think?
I do not think we're ready for school in a month. I'd rather get us over and past the Labor Day and more towards early to mid part of September. The engineering controls and the changes in procedures and everything that'll be necessary, whether it's K through 12 or in higher ed, I think will take a good deal of time for the teachers and administrators to get into place. So I would rather see us pause throughout the entirety of August, and then maybe we can have an in-class room setting or hybridized approach come middle of September, perhaps.
Dr. Norman, thank you so much for taking a few moments. We love a Dr. Norman cameo here in the morning, so we appreciate it. Always good to see you. And to see more from Dr. Norman's new series and more on his interview with Amy, just go to his Twitter page at Secretary Norman. Thanks so much. We'll see you soon.
Okay, I'm going to stay on the line because I want to hear what these other guys have to say. So if there's any questions at the end of the half hour, I'll still be around.
Fantastic. We'll let everyone know you're here. Mm-hmm. All right, Dr. Norman, thanks. Okay, so we're going to turn to Dr. Dana Hawkinson right now. So we heard from Dr. Norman giving us the Kansas story. What is it here? We know we had 4 deaths. The numbers were at 30 yesterday. Mm-hmm. What are we looking like this morning?
Yeah, I like Secretary Norman's point about the masking and how it's becoming a little bit better. Hopefully we can see less hospitalizations, even though right now we are seeing certainly more cases. I think we are doing really pretty good. I'm optimistic right now. We went from 36 last week. We are down to 27 today. So that's really good. We have 6 in the ICU and 5 of those on the ventilator.
So when you see that drop, that's promising to you.
We would like to see that drop because we know that hospitalizations, we know our length of stay in the hospital is shorter for most patients. Obviously, if you go to the ICU and on the ventilator, it's going to be longer. And we know that hospitalizations lag behind cases by 7, 10, 14 days. So if those numbers are low right now, and if we have more of a culture change with the masking and the distancing, hopefully we can continue to cut down on those hospitalizations.
All right, we're going to get to some more questions for you here in just a moment, but let's jump into our topic today. It is an alarming upward trend in violence. Is it linked to COVID-19 nationally and even globally? And what about here in our area? We're going to start with our guest here in studio, Olivia Desmarais, whose job is to help prevent trauma in our communities before it even begins. Good morning to you, Olivia.
Good morning.
So glad you're joining us. So I just want to jump right in because you brought some graphs to really help illustrate what we're looking at and what these trends are. Could you help walk us through that?
Yeah, absolutely. So this first graph here is the total patients seen at the University of Kansas Health System here on the main campus in Kansas City, Kansas. Patients who were injured by violence. So you can see in 2017, 2018, 2019, pretty average between 20 and 30 patients each month. In 2020, March had a significant decrease. April was closer to the average, but then in May, violent injuries seen here at the health system doubled. So you can see that with the second graph, we broke it down to age. Age is 12 to 24. So this graph is specifically looking at those ages because this is the age group that we are working on providing services for through our new program, Revive. And you can see that their trends are very similar to what the first graph was as well.
So we're going to talk a little bit more about Revive in just a moment. But what do these numbers tell us? Because it doesn't seem like a far leap. We like to blame a lot of things on COVID right now, and it's to blame for a lot of things. There's no doubt about that. So help us make that connection with violent crimes and abuse in the home and COVID.
It's definitely a complicated issue, and violence has multifactorial reasons. But I think that the trend is alarming. In March, that violent crimes or violent injuries had decreased. Seems to kind of follow with we were all staying at home, or people were afraid to come to the hospital for their injuries. So that could be a reason. But I think that this is going to be something that's studied long after COVID is gone.
So let's talk about Revive. Tell us about the program, and then I do want to find out how the pandemic has kind of stalled it launching and how it's certainly quite timing right now.
Yeah, absolutely. So just like, COVID-19, we really want to kind of flatten the curve for violent crime. So Revive is a evidence-based way to do that. Revive is a hospital-based violence intervention program that's a community collaboration between the partners that we have here today. Dr. Jomella Watson-Thompson with Thrive, and Damon Daniels with AdHoc Group Against Crime, and then a partnership also with Wyandotte Community Corrections. And so the goal for Revive is to connect patients who have been injured from violence with community programs like Thrive and AdHoc to ensure that they can improve their social determinants of health when they go back into the community. And when I mean social determinants of health, I mean educational opportunities or job readiness programs or safe housing. So Revive, it stands for Reducing the Effects of Violence through Intervention and Victim Empowerment. And our goal is to really make a safe opportunity for these participants to engage in the community and give them the resources they need to succeed. So patients who choose to participate in the Revive program, they'll meet with case managers for up to 6 months, and those case managers through Thrive or AdHoc are going to help them set goals and then help them connect them with resources in the community to meet those goals. As with COVID-19, our original plan was to launch in April, but obviously because of the pandemic, we stalled for a few weeks to revamp our processes and to make sure that they were socially distant. So we changed the way that we were going to respond to the hospital a little bit. But yeah, we're up and running now, and we've had some of our first referrals come through. So.
All right, so I want to bring in our other guest that you work with Revive, Damon Daniel. He's the president of AdHoc Group Against Crime. Good morning to you, Damon. How are you?
Good morning. Thanks for having me. I'm doing well.
Good. Okay, so I just want to find out a little bit about your role with the Revive program.
Yeah, well, the AdHoc Group Against Crime essentially responds much like a community health worker. Our role is to respond to the hospital and follow up with those individuals who've been intentionally injured, particularly youth between the ages of 12, youth and I should say young adults between the ages of 12 and 24 years of age. And so part of our role is to intervene and make sure that there's that we try to reduce retaliation, reduce re-injury, and even decrease arrest rates as well by promoting alternatives to violence as well. And so part of that means we're connecting people to local community services, making sure that there's counseling services available for those individuals as well, and really just kind of wrapping our arms, the community arms around these individuals and their families.
And Damon, I know you brought up an interesting point when we were speaking earlier about how even if we're not seeing a scientific connection between COVID and violent crime, that you were saying due to COVID, maybe people's eyes are much more wide open to the disparities in our communities. Can you expand on that just a bit?
Well, sure. I think a lot of folks are staying at home. They're on their phones a lot more. And so this epidemic of violence that has been occurring in our communities for many years is a lot more on our minds now. It's a lot more in our faces and on our television screens and our phone screens as well. And so what COVID has done is essentially awakened some from their slumbers as it relates to the injustices that have existed for a long time, but also I think has provided a way for folks to get involved as well. You know, it has indeed exposed some of the inequalities that have existed when we talk about access to, affordable care, when it comes to preventable diseases, and the disproportionate number of people of color that have been affected by COVID-19 as well. There's sort of a direct correlation when you look at the communities where high rates of violent crime and homicides are occurring. It's also where we are seeing some high rates of people infected by COVID as well. And a lot of that, again, has to do with some of the social ills that have existed for quite some time.
Dr. Watson-Thompson.
I will say this, one of the things that COVID is doing is reducing in terms of our connection to people as well. And so in most cases, we would really meet with people in person, have these dialogues, really make sure that we're connecting them to the services that they need. But with COVID, we have to take extra precautions and use technology, talk to people over the phones more, and things like that. But we're still doing our best to connect people to the resources that they so desperately need. And that's, I think, one of the beauties about this program is that we are reaching out to those patients as well, primarily even after they are released from the hospital. So it's that extra continuation of care.
Yeah, that was one of my questions. How are the people you serve affected by this pandemic? I want to talk a little bit more about that, but I want to bring in Dr. Watson-Thompson. How are you today?
I'm well, thank you.
Good. Well, so you're an expert in psychology and leading the local efforts to address youth violence. So could you tell us about, well, first, just your participation with the Revive program as well?
Sure. So Revive is a collaborative effort through Thrive. And Thrive is a coalition of over 50 community-based organizations that come together to really think about what it is that we can do to help to improve our outcomes for our youth, including related to violence. And so how do we do that related to addressing conditions across systems? And so what I think is very unique about Revive, particularly as one of the key efforts with my colleagues who are on the line, and also the Wyandotte County Community Corrections is also another key collaborator with Revive for us, is really helping to determine, we know that we see the outcomes or the effects. So our young people end up in ER or in the emergency department or units due to, in this case, intentional injury or violence. What we need to know and what we're understanding and what our colleagues with the health system and many others want to better address is what got that young person to the ER in the first place, right? And how do we begin to address those conditions, both at the individual and the community level, so that we can reduce the likelihood that that young person and their family or friends will return to the hospital, but in general, they can fulfill their full potential. One of the notes that I think Damon made that is great is that really through these the conditions that we're experiencing right now with COVID, it's exasperating, or we're seeing the exasperated effects of many other interrelated problems and conditions. And then you layer that on top of our social injustices. I think the question we have to ask are, why is it more likely that some individuals or some groups right now are experiencing elevated rates of violence, elevated rates of food insecurities? We have our young people in, we know the educational system right now, they're trying to figure out how they're going to navigate the fall semester. So there's a lot of different interrelated factors and a lot of different systems that we have to be moving simultaneously if we really want to be able to address violence. And the hospital and the health system is modeling that, bringing us together as a community, as well as many of the other social determinants of these underlying factors that Olivia addressed earlier that we need to be looking at systemically.
Well, and on that topic, I mean, I think there's a lot of us sitting at home feeling desperate to help. We don't know what to do. It's kind of a see something, say something, turning into kind of a see something, do something. What do you think we need to know as a community? How can we help kind of right now as we head forward into this? What can we be doing in our communities to assist all of us together collectively?
Definitely, because that is what it takes, is a very comprehensive approach for how we're able to address COVID-19. The lens I'm always taking are particularly those effects for our youth and families. How do we address, layer on top of that, the social injustices that we're experiencing and the inequities in general? And so one communication or consideration in regards to that, I think, is determining what our opportunity points are. So whether you're the health system, whether you're the social service agencies, whether you're the neighborhood and community organization or the resident, what we can do. What we know is our youth and families in our community, we're experiencing trauma, both at the individual and the community level. We have young people and families, they don't know where their next meal is coming from. The services we generally and traditionally have provided are harder to access. Transportation is more challenging to get to those resources. And so a lot of what I think we have to do is first acknowledge at the individual level what's occurring, but then across the broader parts of the ecology. But your question is, what can we do? I think it's important for us all to determine where we have some influence points, whether that's your neighbor, just checking to make sure that they're okay, whether that's your organization or your agency, determining how you can make your services accessible in a very different way than we've had to do before, or if it's linking arms with initiatives such as ours, such as Thrive. The community health and the health department has done a lot of efforts through a newly formed health equity group to really think about how do we better communicate and coordinate the resources that are out there and that are available. And so I think a lot of it is determining and helping to mobilize with us in the community regarding how we can be more coordinated and more integrated during this time, so that it's not so hard and it's not so difficult for our youth, for our families, and for our community to be able to determine, identify, and access those resources. And so I'd invite you to consider Revive, Thrive, the Health and Equity Task Force work that is occurring, and then seeing how we can layer on top of that so that we have a more comprehensive approach.
such an interesting topic. So we're encouraging our viewers and the community to bring in some questions this morning. So we're going to get to questions. I'm going to see if the media has any questions. And just a reminder, Dr. Lee Norman is on the line as well. He stuck around for us. So if you have any questions, let us know.
Good morning. It's Shanu with KDHE.
Good morning.
I have a question about hospitalizations, like month to month. How are hospitalizations looking at the beginning of the month and the beginning of July compared with, the beginning of August? And how are things looking that way?
Dr. Hopkinson, do you want to start? And then
I can start with that. I don't have any of those firm numbers down for the trends, but we know, as Dr. Stites has organized the CMO teleconference, and we've had some of the CMOs from the other hospitals on yesterday, in talking with some of our partners around the community, about a week or two ago, I guess, more like 7 to 10 days ago, we probably hit our peak number of COVID patients in the hospital throughout this whole pandemic, and that was, I believe, up to 160 or 170, quite a bit higher than it was in April. So we had a peak, a lull, and then again a peak probably about 7 or 10 days ago. I think, and hopefully, as we have seen in our hospital, a decrease in overall cases, and we heard from the CMOs yesterday from the other hospitals that they've seen a little bit of decrease in their cases as well. So hopefully we can continue that trend.
I did actually get the numbers from Dr. Wild,
Okay.
because another reporter asked this question yesterday. The average inpatient for April was 31. June, it was 18. In July, the first 2 weeks, it was 23. The last 2 weeks was 37, was the average.
So it went up, and hopefully, as we get into August now, we can continue this downward trend and keep the lower numbers.
another question? Media? Jill, let's get to our community questions.
Okay. Cindy wanted to know, if not COVID, what do you attribute the spike in violence to?
Olivia, do you want to start, or do you want me to?
Yeah. I think it is probably difficult to say, honestly. And like I said, I think it's going to be something that's looked at long after COVID's gone. The trauma data numbers that we have here lag by 60 days. Our trauma data registry doesn't give us numbers to 60 days, which is why I don't have any data past May. In previous years, we'd saw, if you go back to that graph, there was a spike in youth violence injuries seen in the health system last year in May in 2019, and then they tapered back down. I think that, like I said, they're multifactorial. I think that it's a complex problem, as Dr. Jomella Watson-Thompson kind of alluded to.
I think those are some of I think the factors. You say it's multifactorial. What are some of the factors, I think, is what she's wondering.
Yeah, I'll defer to Dr. Jomella, because I think that she is the expert in those, yeah.
Now, Doctor, what's your insight on that?
Definitely, Olivia. Thank you. So I think what we see and what we've been trying to address through Thrive and many other youth violence prevention and community violence prevention initiatives are the underlying factors, the determinants that Olivia approached earlier. It's related to employment, right? And education, our connectedness, how accessible we are to each other, our basic connection to resources. We know that these underlie not just violence, but many interrelated problems that we experience in our communities, which is why that's what we ultimately need to be able to move and to change conditions. And so I'm now more concerned because my family now has increased economic insecurities. I'm going to do what I have to do to make sure that my family is taken care of. And so in that way, we're going to see some results. And so, or some effects. And so I think a lot of what we have to ask is, yes, we would consider COVID-19 a setting event or a contextual factor that is definitely contributing to what we're seeing occurring. But we have to then take a step back and say, okay, but more immediately, then what did that relate to? So that related to a person who's no longer employed. What are they now having to do now? That's relating to a person who no longer knows how they're going to feed their family. What are we doing now? And so that's where we then have to take a step back and address some of these interrelated factors that we know through years of research undergird a lot of what we see. But then you put COVID-19 on top of that. You put the trauma on top of that. You put the insecurities on top of that. That just further exasperates it, and it makes it kind of an elevated rate is really what we're seeing, right? And so that would be my response in regards to what we know contributes to, in this case, violence and many other problems. But then when you layer on top a lot of other unrest, then it magnifies it.
Judy wants to know, what are signs of violence to look for?
That's a great.
Dr. Watson-Thompson?
Actually, I'm sorry. I'm going to defer to Damon, and I can tag him a little bit.
Let's bring you in on that. What are you hearing?
Yeah, you said, what was the question again? Was it some of the signs of violence?
What should we be looking for in others that means there's a sign of violence?
Well, I mean, there's a lot to undergird recognizing some of the signs. When we talk about poor parental supervision, we talk about disconnectedness as it relates to some of our youth, particularly when it comes to their terms of their connections to other youth and or their peers. There's a lot that has to do with what goes on in the home in terms of how people are resolving conflicts without violence, the kind of mentoring and or positive influences or lack thereof that folks have in the homes or youth have in their homes as well. I think Jomella or Dr. Watson-Thompson talked about this a little bit too when we talk about employment insecurities. Those are some of the sort of early, I would say, warning signs of that violence could occur because of some of those social factors that have been mentioned previously.
Then I guess my question is just if I'm living next door to somebody who I think is in a violent situation, what am I supposed to do? Do I butt in? Do I make a phone call? What are the steps? What are you recommending to get the best result?
Well, I think certainly as it relates to if there's a youth that you believe that's endangered, certainly highlighting that family is important, but also making sure that people actually have access to resources as well. So sometimes it could be a matter of making sure that people know where they can go and get food, where employment opportunities are, making sure that they have access to the education that they need, making sure that people have access to mental health services. Lots of times people are dealing with so many stressors in their lives that they're not necessarily doing the checkups that they need in terms of mental health checkups as well. So making sure that people have access to mental health is extremely important, especially if they've been exposed to some sort of violent act. How they are coping with that is extremely important as well. So making sure that people have access to counseling services is very important too.
Jill?
All right, we've got some infection-related questions for a little bit of a change in topic. Anne from Sedalia watches every day, and she wants to know about an Australian trial in July using Symbicort.
Okay.
Does it work?
Yeah, there's been a lot of talk about some of these. There is no, again, we've said there's no magic bullet. I don't know that it would offer real benefit. There certainly has not been anything published on inhaled types of things like corticosteroids. It probably will not harm you, but there's been no benefit. I really anticipate it probably will show there probably won't be too much benefit compared to the other things that we're using, and that's plasma, remdesivir, obviously vaccination once we can get it, the steroids that we're using as well, and the anticoagulation. Right now, those are the best things we have. Any of the inhalers, they probably won't do any harm, but I don't really anticipate they're going to be showing much benefit.
Quinn wants to know what Dr. Norman thinks about. Nationally, there are predictions being reported that when school gets back in session and the weather gets colder in the fall, that we're going to have higher numbers as people move indoors. Is there any way to avoid that?
I think that I agree with that. And I'm basing that somewhat on what's seen in Europe already. In the UK, there's a new Lancet article out that looks at predictors for COVID-19 activity related to schools. And I think it's a testimony to the fact that, as pointed out, people are in closer approximation. I know that if the engineering controls, distancing, changing of schedules, wearing of masks, hand hygiene and the like, we know that will lessen the kind of quote-unquote second wave. But the forecasts in Europe, which are already back at it, is that it'll be twice the peak from the first wave. At least that's what I'm reading.
All right, Mike has got another school question. He says, my son's district announced they were planning to continue their gifted program in person. They have to bus the students from 7 or 8 schools in the center daily. Each day is a different grade level. He thinks that's going against the advice on cohorting and exposure. What do the doctors think?
Dr. Norman?
Yeah, I think it's a subset of the earlier one, which is if we pull it off well and do the public health measures outlined, I think it will minimize it. One of the things that's critically important, though, to remember is if somebody's sick, not to let them in and to get them out of that setting, and then whether it's the medical community or the public health infrastructure, rapid testing of everybody that's symptomatic, rapid contact tracing. And to do that, we need to have a quick turnaround on the test results. I see this as a big vulnerability right now. If we're getting on some of the commercial labs 7-day turnaround on the tests, that is not going to work because that won't allow us to do the things we need to essentially immediately when somebody's symptomatic. We need to find out, make a diagnosis, and figure out if they have COVID-19.
So school doesn't work without rapid testing, basically.
That's one of the major components for sure. When we talked about school starting 3 or 4 weeks ago, the infection dynamics, the climate was much different than it is now. And if it continues on this trend, if we don't have everybody masking and physically distancing and really cutting down on the new cases, then doing that proposition with that gifted program for that question specifically is going to be very dangerous. And just to echo Dr. Norman's statements as well.
Another question for the doctor. Suzanne says, Kentucky added Kansas yesterday to the list for quarantine due to an 18% positivity rate. Her question is, where does that number come from?
Dr. Norman?
That's not an accurate number. We're not anywhere near 18%. I don't know where that came from. And we have that on our website. And I might suggest to people listening in that our microsite on the KDHE website publishes it every day. And we're right at about 9.5%. We've barely been above 10%, and it's getting better. We've never been anywhere close to 18%, so I don't know where that number came from.
Well, the question is, though, too, how do you get that number?
You mean how is the number computed?
Yeah, where does it come from?
It comes from our agency. We take the total number of cases and divide it by the number of positives and divide it by the total number of cases, and we publish it every day on our website.
Okay, Cheryl.
We're the ones that give it to Harvard. We're the ones that give it to the Harvard Global Health Initiatives. We're the one, and Johns Hopkins gets it from us. We get the numbers of positive tests are fed into our epidemiology tracking system from laboratory directly through electronic submission, as well as the local health departments verifying it. We aggregate the data and submit it to the CDC, to Health and Human Services, and then that's the numbers they should be going on. That's why it's a puzzler that it's 18%. We've never had anything close to that.
Cheryl has a question, again for the doctors. My niece got sick and tested positive for COVID. Her daughter has the same symptoms and tested negative. How can that be? Is there a possibility that one of the tests was incorrect?
Dr. Hawkinson?
Yeah, I think that it's a pretty good story for somebody who hasn't tested positive and somebody else gets the similar symptoms. We've talked about this before. It could certainly be operator error, meaning the person performing the test didn't get the adequate sample. These tests are very specific, so they can even pick up small numbers of the virus if you are shedding virus. So that could be. It's really hard to tell exactly why without knowing the circumstances, what lab it was, whatever, etc. I think the safest thing to do is, again, to continue to, if you live in Kansas, obviously look at the Kansas Department of Health and Environment website on when you can come out of isolation. Right now, you should probably be isolated because of, We know that you're positive and you have symptoms and your daughter has symptoms as well.
But the daughter's negative. Does the daughter need to get another test? Because I would want to go get another test.
Yeah,
just to make
I
sure.
probably would not recommend another test.
don't
You can
need
do that. Again, we've talked about how fast can you get back the test results as well, so that will matter. Dr. Norman just talked about that. I think with the symptoms and with a known positive test in the school or in the household, you're probably better off kind of isolating for that amount of time that you need to be isolating.
Jill?
Yeah, we have time for a couple more maybe?
Yeah, let's do it.
Okay, all right. So Cindy wants to know what the doctors think about a recent study concerning cardiomyopathy and heart failure related to COVID. How does COVID impact the different organs in the body?
Yeah. Well, we do know that the receptor, the ACE2 receptor that the virus uses to enter our cells, is really prevalent on cells in the lung, but it's also prevalent on other organs such as the heart, the GI system. We understand that there have been some autopsies done on patients who've died because of COVID. We also understand that there's I think it was a German study or a multinational study looking at, well, what happens when people survive? How does it affect their heart? We know that there's MRI changes even 2 to 3 months after becoming infected with COVID. So we know that it does affect it. We know that the virus can infect the heart. Different people will obviously have different outcomes with that as well. Some of the autopsy studies, when they actually tried to look for the virus and stain for the virus, they did not find it in the heart. Other studies, when they looked for the RNA or the genomic material, did find it in the heart cells. So we know it can affect it. The scary thing about this is even people with mild to moderate disease who survive seem to have changes in their heart even 2 to 3 months after survival as well. So that's concerning.
Jill, last question?
Yeah. So the doctors, we have a question from Angela, and it has to do with there were upticks in the numbers after Mother's Day, Father's Day, Memorial Weekend, July 4th. What are you expecting after Labor Day? And they're concerned about that going into the fall.
Dr. Norman, do you want to start us off?
Yeah, we would expect an uptick. Anything that drives gatherings of people has had a demonstrable increase. Usually 4 to 7 days after the gatherings or the gathering weekend is when the cases start materializing. The data entry lags just a little bit because it takes some time for people to get tested and then results to come back. So we've been seeing it kind of upticking about 10 to 14 days or even out as far as 21 days just in terms of the data catching up with us. But I absolutely predict that people will drop their guard again and we'll see an uptick. And that would be very unfortunate timing if it puts the next peak at the time when people are entering school.
Yep, that's what I was just going to say. Just in time for school. Dr. Hawkinson, any thoughts on that as well?
Yeah, no, absolutely. We know, again, the cases will lag a few days behind. Hospitalizations will probably lag 7 to 10 to 14 days behind that. And again, during that time, if people aren't practicing good, optimal practices, there can be even further spread as well.
All right, we want to get to our final thoughts from our panel of guests who've been so great today. We really appreciate this conversation. But I want to start with Dr. Lee Norman. Can we get your final thoughts today?
Well, I think in the absence of a good federal strategy, and it's been an absent federal strategy all along, we really have to make people understand or help people to understand that they own their own preparedness, and just to be very mindful of the things that Dr. Hawkinson and Dr. Stites and all of us have been talking about is pay attention and don't do the things that are going to get you infected.
All right, thank you for that. We'll get to the rest of the panel here in just a minute. But on tomorrow's show, we just want to remind everyone that Dr. Salate, the chair of internal medicine, joins us to talk about COVID-19 therapies and vaccines. Also, Dr. Amanda Ollinger. She is a pediatrician and the president of Kansas Association of Addiction Professionals. And she's got a worry that she has as students head back to the classrooms during this pandemic, and it's something the parents are going to listen to. So join us for that tomorrow. So, Olivia, I want to just get some of your final thoughts as we head out today.
I think that this is, violence is something that we're going to continue to measure and collect data on here at the University of Kansas Health System and continue to collaborate with our community organizers like Jomella and Damon.
Damon, your final thoughts today?
Well, I would just say that just know that violence affects all of us, whether indirectly or directly, and we recognize that, it's the leading cause of death for youth between the ages of 10 and 14, as well as those between the ages of 15 and 24. So one of the things, there's three things we can make sure that we do as a community, and that's making sure that we are investing in individuals. That means our time, that means our talents, et cetera. Investing in places where there's high rates of violent crime and homicides, making sure that we're leveraging the kind of resources that our community members and neighbors desperately need. And then thirdly is that, violence is a learned behavior. And so making sure that we are investing in behavioral change as well. And each of us can play a part in that, whether it's modeling good behavior and conflict mediation behavior and things of that nature. But most importantly, practicing forgiveness, because when we are all able to forgive, we all walk away whole as well. And thanks for having me, folks.
Oh, you bet. Great message. I appreciate that very much. Dr. Watson-Thompson?
Yes, thank you. And so I would just leave us with that there is a part and opportunity that we all have to contribute to really being able to think systemically about how we can contribute to addressing violence as well as related conditions such as COVID-19. One thing I would note is that our youth and our families definitely during this time need to be supported. And so just thinking of what we can do to continue to wrap our arms in ways that are integrated around our youth and our families is key. And so if there are resources or if you need to know additionally what you can do, you can always contact us at thrive@ku.edu, thrive@ku.edu, where we would love to share more about Revive, as well as other collaborative efforts that are thinking about the disproportionate impact that some of our community are experiencing as it relates to violence as well as COVID-19.
Thank you, all three of you, for sharing your insight on this really, really important topic. We really appreciate it. Dr. Hawkinson, final thoughts from you today?
Yeah, as we move forward, trying to understand what is the safety of our children returning to schools. As Secretary Norman pointed out, it's down to self-preparedness. If you can continue to do those items that we've talked about, the masking, the physical distancing, the hand hygiene, it is a conscious effort, but if you continue to do those things, it will be subconscious. And in that way, we can hopefully flatten the curve and get back to schools. And most importantly of all, not suffer another shutdown or quarantine like we had early in the spring.
All right. Well, thank you for everyone for joining us today. As always, we love to send you off with some reminder pictures of people doing it right out there, social distancing, wearing their masks. So check this little one out. This is Terry actually sent this picture in of her granddaughter Reese. So she makes these little lanyards that you can put your mask on. I wish I thought of that. That's such a clever idea. But this is the cool part. All the proceeds go to a local food bank. So way to go, little one. That's so cute. And then Craig sent this in, some chalk art. This is his daughter, Cadence, and she did this without any prompting. We know what we always prompt our kids to do stuff, and she did this on her own. She said she wants people to listen up, wants everyone else to learn the importance of social distancing and staying safe. So thank you, kiddos, for doing that. We appreciate it. And you can continue to send in your photos. There's the information right there at KU Hospital. Also go to Medical News Network at kumc.edu. Send those pictures in. We like to see those, and we really appreciate all of you joining us here today. Make it a great one, and we'll see you tomorrow.